All right, welcome to the world of transfusion medicine. I forgot to mention um, in the last part, we're talking about complications, and certainly another big complication we see um, is well, there's sort of the dilution effects that we have when we give fluids, and the book describes that well. The other one is when we start, you know, we we can also cause things like hypokalemia and hypernatremia. We talked about that in the preceding weeks, and and then something that's a little harder to understand though is we can also affect the acid-base balance. Again, this a typical kidney is going to be able to help prevent us from screwing things up, but it's kind of worth knowing that um, certain fluids are they have a kind of a benefit. Fluids like lactated ringers, um, you would think with the word lactate, and lactate is an acid, you would think that lactated ringers would make your patient more acid, more acidic. Actually, that's not what happens. Um, um, it has to do with what I think what the liver does to lactate. Anyway, lactated ringers will actually do the opposite. It'll make a patient a little more alkaline, and that's great because patients who are in shock, right, they tend to have lactic acid building up. They tend to be a little acidic. Again, it sounds backwards. Like if they already have too much lactate, why would I give them lactated ringers? Just, it's not what you think. Um, Lactated ringers is exactly what they need, again, because it has an alkaline, or alkalinify, I can't say it. It will make them more alkaline, okay? Um, Sodium chloride, for some reason, will make patients a little more acidic. Um, the Again, we don't really worry about that too much. Most of your patients are going to be acidic, but even if they were already acidic, if you had to give saline, you're going to probably be okay. But if you were to go do more kind of advanced work in critical care and emergency medicine, um, then it might be a bigger deal. I mean, to me, the big thing, the big reason we would use saline instead of lactated ringers would be if the patient already had either we don't know their potassium status or their potassium levels are already high. So a blocked cat, a blocked goat, um, a dog with Addison's, right? All those patients are going to probably have high potassium. I had a little dog with a ruptured bladder, right? He was attacked by a dog, his bladder ruptured, his potassium was high. Those patients did not get lactated ringers. They got saline because it had no potassium in it. I didn't have to worry about, causing cardiac arrest. Anyway, okay, now let's talk about transfusion medicine. That's where our next set of learning objectives are, and we're going to use Rocco as an example. Now, Rocco is a real patient, but I'm not going to tell you his history. It doesn't really matter. Let's just say that Rocco comes in. Owner chief presenting complaint is that he's lethargic, and we look him over and we see that his gums are quite pale. They are quite white. It's a little hard to appreciate, but there's all this pigment. This is normal pigment, but he's got really everything's pale. We order some initial tests, and he's got PCV of 12%. What should his normal PCV be? I don't know exactly what it should be, but I'm pretty sure it shouldn't be 12%. It should probably be more like 40% or 45%, right? Somewhere in that range. So, um, and with Rocco, there's a very simple little test. So let's say we're running the CBC and the chemistry panel. Something we can do that's quite simple is checking for auto-agglutination. And what that means is a glutinate kind of has the word glue in it, right? Glue. it just means kind of things clumping and sticking together. Clumping is a good word for it. And what's clumping together are his red blood cells. That's what we're looking for. So when we have a patient who's extremely anemic, right? That's the definition of anemic, is a low PCV. We can just take a drop of blood and mix it with a couple of drops of saline for a dog, or a little more for a cat. And normally it should just look like, kind of a pink, just kind of a pink color. But you see, this Rocco's blood is kind of chunky looking, isn't it? It's a little chunky and clumpy and agglutinated. So this would be positive for auto-agglutination. And again, it's referring to, by auto, we mean, it means, you'll see what it means, but it means his antibodies are making his red blood cells clump together. And this is what it would look like. You could also look at it under the microscope, because you want to make sure it kind of gives you additional proof. And just as a reminder, there is that thing called rouleau, the French word for like a stack of chips or coins, right? This would be normal. Normal in a horse, could even be normal in a cat. You see these little stacks, right? Here, it's just little chunks, clumps and chunks. So that's, we don't see the little stacks of coins like we do in rouleau. And this is what is happening with auto-agglutination. We got red blood cells getting coated with antibodies, and then that's one of the things. Antibodies do a lot of amazing things, but one thing they do is they make pathogens clump together. Staphylococcus, streptococcus, whatever. The problem here, though, is that Rocco appears to have an immune-mediated hemolytic anemia. Immune-mediated is another word for autoimmune. It means that he is attacking himself. He is making antibodies against himself, specifically against his own red blood cells. Right? His body thinks that his own red blood cells are pathogens. His body thinks his own red blood cells are pathogens. Yikes. And so, anyway, that's what's happening. We'll learn a little more about that a bit later. So, certainly a question we will ask is, well, does he need a blood transfusion, and how do we decide that? Well, let's start first by just talking about. We'll come back to Rocco. You'll see him again later today, and you'll see him next week. But let's say, well, what are some of the blood products that are out there? There's several types, and there's some videos that we'll watch next week as we review this. But there's whole blood. That's the easiest to understand, right? It's red blood cells, it's plasma, it's white blood cells. You can also do what are called packed red blood cells, and that's just the red blood cells. I'm sure there's some liquid there, but there's no plasma, basically. There's no, there might be white blood cells, I don't know, but it's basically just the red blood cells without the liquid. You can do a thrombocyte transfusion, you could do a plasma transfusion, and there's something called cryoprecipitate. That's referring to von Willebrand factor. And we'll talk about that. When do patients need a blood transfusion? Again, when I say blood, it could mean plasma. So maybe I should just say, when do they need a transfusion? That might be more accurate. When do patients need transfusions of one of these products? If there's acute hemorrhage, like we see here, sometimes the hemorrhage is external. A patient, cuts a major artery. Sometimes it's internal. Sometimes they're bleeding into their abdomen, and something we won't talk about is what's called auto transfusion, but you may see that where we take blood from the abdomen, for example, and we just transfuse it right back into the same patient. Why not? Um, but anyway, both of these would be cases of acute hemorrhage. There could be hemolytic anemia, and you'll see why that's a little bit different. There's chronic anemia, and we'll talk about that a little bit too. What would you expect on Rocco, for example? What kind of vital signs, etc., would you expect? Well, you'd probably have pale mucous membranes, rapid heart rate, rapid respiratory rate. They're often very weak, right? Because they're just not getting the oxygen that they need. They just don't have enough red blood cells. Obviously, a decreased packed cell volume and total protein. And you may recall back, we've talked before about regenerative anemias and non-regenerative anemias. And that's real important for treatment and prognosis. It's real important to try to determine whether this is regenerative or non-regenerative. Again, this applies to, to anemia. So again, a regenerative anemia means the bone marrow is responding. The bone marrow is trying to regenerate or generate new red blood cells. And the new red blood cells are the reticulocytes. Those are those slightly immature red blood cells. So these reticulocytes tend to be bigger and paler. They're bigger and paler, or more pale, than the mature red blood cell. And so we call that macrocytic and hypochromic, and that tells us, good, bone marrow is trying, it's cranking out all these new reticulocytes. But if a CBC comes back and it's not macrocytic and hypochromic, then we say, oh, shoot, the bone marrow doesn't really seem to care. We call that a non-regenerative anemia. And again, what tells you if something is macrocytic or hypochromic? It's that MCV on the CBC and the MCH and the MCHC. Those are what we look at. And then, of course, we also mentioned you might use autoagglutination to see if the patient has a particular kind of anemia called an immune-mediated hemolytic anemia. There's different kinds of hemolytic anemias. Immune-mediated is just one kind. Other kinds of hemolytic anemias, like cats can get that Heinz body anemia from eating like onions, or from getting too much like repeated doses of propofol. That would be a hemolytic anemia, but I don't think there'll be any autoagglutination. Anyway, okay, something the book talks about is that with, it's important to check PCV total protein, but it's not perfect. It's not perfect with acute hemorrhage. And the book describes how with acute hemorrhage, the PCV total protein is not going to change right away. So I'm going to give you a little example here. And again, this is supposed to be representing a horse. That's his blood volume, right? He's not wearing red pants. That's just supposed to be a horse. That's the blood part of a horse. And then, of course, all this horse is losing all this blood, maybe from his nose and in his diarrhea. And now he's got less blood in his body. What I'm going to try to explain is that in the first hour or so, his PCV total protein is the same. It's the same here and here. And I'll explain why in a moment. It might be less than an hour. So here's a little example. This is you at the beach. Okay, you've gone to the beach. You're having a great day. Your PCV happens to be 45%, right? What does that mean? That means that, in your blood, 55% of it is liquid or plasma, and then the other 45% is your red blood cells. So this is saying that in your blood, 45% is actual red blood cells, and 55% is plasma, right? Okay, now let's imagine that your leg was just bitten off by a shark, and now you're losing a lot of blood. All right, you bandage your leg, but you've lost a lot of blood, okay? Now, here's what I'm getting at. Is your PCV, if we were to check your blood sample at the beach, I realize that's impossible, but if we checked your blood sample at the beach, moments after you've lost all that blood, your PCV is still 45%. It's still 45%. And I'll explain why in a moment, but it's because, just have to kind of think about that. Imagine the blood pouring out of your leg, and we catch some of that blood. What's the PCV going to be? Well, 45%. If I get a sample from your jugular vein or your whatever, it's going to be 45%. That's because nothing else has changed. All that's changed is all this blood is pouring out of you. To understand what happens, why it changes over time, we need to go back to talking about your fluid compartments. Remember, most fluid in your body is actually inside your cells. You have a lot of fluid in between and around your cells. That's your interstitial fluid. And actually, the least amount of fluid in your body is in your intravascular space, in your veins and arteries. And so, just I want you to imagine, right? You've lost all this blood. Let's say you've lost a few liters of blood, and you're driving to the hospital, or maybe your friend is driving you. What's going to happen? You've lost a lot of fluid here, right? Hold on. Right? In here, you've lost a lot of fluid, right? It's lost. Okay. So what's going to happen in your other compartments? What do you think is going to happen to the fluid in your intravascular space? Your intracellular space and your interstitial space. What's going to happen? Or the way I phrased it here is fluid going to move from the intravascular space into these spaces, or the opposite? Is fluid going to move from these spaces into the intravascular space? What do you think? Well, the fluid is going to move, say, from here over into here, and from here into the intravascular space. In other words, your body, I don't know how, but your body recognizes that that your blood pressure has dropped. Well, I know how your body knows blood pressure has dropped. But to fix it, your body sort of recognizes that you need fluid to move into your intravascular space. It's really probably just a matter of osmosis, of things going from high concentration to low concentration. So that's probably why the fluid will move out and into the intravascular space, because there's just less water there. But the point is, now you still have a certain amount of blood in here, but now it's being diluted by all this fluid coming in. Let me repeat that. When fluid moves in, right, it's just fluid, so it's going to dilute whatever remaining red blood cells you have here. And that's going to give you a much lower PCV. I think, let's see what the book says. How long does that process take? Yeah, it says it'll decrease as body fluids redistribute over the first 12 hours. So it takes some time before your PCV, if you've lost blood or your patient has lost blood. What I'm saying is a patient could come in, it could be, or you might rush out to see this horse or that cow or that dog, and they've lost a lot of blood. You check their PCV, and it looks great. Oh, well maybe so what should you think? Should you think, oh, they're fine? Or should you think, well, yeah, it's normal. The body hasn't had a chance yet to shift fluid into the intravascular space. That's kind of the point, is that the PCV total protein may things might look better than they are. Okay. When do we transfuse? How do we know when to transfuse? The book gives some guidelines that are pretty standard in emergency medicine. With acute hemorrhage, right? I would take that to mean blood loss within, an hour or so, or a day, I guess. If the PCV is less than 25%, we should probably transfuse. You could use whole blood or packed red blood cells. In a chronic anemia, though, the PCV can be lower. It could be below 12%. And again, we might use either whole blood or packed red blood cells. Why the lower PCV in a chronic or hemolytic anemia? Why would that be? That's quite a bit. That's 8 percentage points lower. Well, a couple of reasons. One is with chronic anemia, like say from kidney failure or leukemia or something like that, the patients had time to adapt. They can compensate. So these patients could have 15, 16, 17, 18%. They don't look that bad, to be honest with you. They would look very much worse if it had been acute blood loss and they didn't have time to compensate. The other reason is these patients with chronic anemia and hemolytic anemia, they're usually not hypovolemic. They're not hypovolemic. They've lost red blood cells, but not plasma. So they're not hypovolemic. And so, but patients with acute hemorrhage, we'll talk about, have a double whammy. And I'll talk about that in just a moment. Okay. Another guideline that McKernan gives is to transfuse if blood loss is greater than 30% of the total blood volume. Now that would be helpful if they were bleeding externally, and you learned at the very beginning of chapter 25, you learned, well, what is the blood volume, right? It's that same number. In dogs, for example, it would be dogs, it's about 80 to 90 mils per kilogram. Cats, it's about 40 to 60 mils per kilogram. A horse is about 80 mils per kilogram. So you could just say, well, okay, if it's a cat, you just multiply whatever, 40 mils per kilogram, just figure out, his weight in kilograms, and then take 30% of that, and you could maybe get a rough idea. I don't think that's all that helpful. It's, how do you know? How do you know if it's been 30%? But you could eyeball it. 5 kilogram cat would have a total blood volume of 5 times 40, so about 200 mils. 30% of 200 would be about 60 mLs, right? So if you think the cat's lost 60 mLs of blood, maybe he needs a transfusion. Just a few other little tips and a question I wanted to ask you was a tip would be, a good one is that we always want to treat the patient and not the numbers. Treat the patient and not the numbers. If a patient has a PCV of 15, or let's say it's a chronic anemia. Let's go back here. Let's say it's a chronic anemia and they have a PCV of 18%, but they look like crap. They look like they're dying. Well, maybe we better do a transfusion, right? On the other hand, you'll see patients, they'll have a PCV of like 9% or 10%. They look pretty good, and you're thinking, I cannot believe you look this good. Your blood is like Kool-Aid. Your blood is like Kool-Aid, and you look pretty good. That patient we might transfuse, or we might say, let's just see how he does. because you'll see there's some risks with transfusions. But my point is, we don't just look at the numbers. You have to look at the patient too. Like I said, the double whammy of acute blood loss is, one, they're anemic, they've lost blood, but they're also they're anemic and hypovolemic because they've also lost fluid. Patients with immune-mediated hemolytic anemia or leukemia and things like that, they may not be in hypovolemic shock. They're anemic, but they actually have a normal blood volume. So that's one good thing about those kind of conditions. Okay. So again, let's talk about some of the different blood products here in a little more detail. Again, what you're seeing here, this is probably whole blood being transfused. Again, that's everything, right? That's the kind of the easiest one to understand. This is great if patients are actively bleeding, if there's been massive blood loss, and if they're hypovolemic, right? It's going to help with all three of those things. I'm not sure what I'm doing here. Okay. Packed red blood cells are when they need blood cells, but not necessarily fluid, right? They're normovolemic, but they need red blood cells. Maybe they have a hemolytic anemia or a chronic anemia. So there's been no volume loss, just red blood cells. And I think this is a bag. Again, I don't know if you can tell by looking, but this is probably packed red blood cells. It's a bit denser looking. Plasma, we actually have plasma in our freezer here, so I'll have to remember to bring that out to show you. So remember, what's in plasma? There's no red blood cells, there's no white blood cells, but there's a lot of other good stuff, right? You've got clotting factors, you've got albumin, there's antibodies. So people who are fighting off COVID, like President Trump, probably got some sort of a plasma transfusion. My father had COVID and he survived. Thank goodness. He probably got some sort of a plasma transfusion or something with antibodies. So again, clotting factors are useful if a patient has eaten vitamin K, a vitamin K antagonist, like a rat poison, like Decon or an owner's warfarin, liver disease, DIC, rattlesnake, bites. These are all things that can cause bleeding disorders. Albumin is useful if you have a patient with hypoproteinemia. We can treat them with plasma. Probably the two things I used it for, well, again, rattlesnakes, also puppies with parvo. They don't have antibodies yet. We could take maybe the mom's plasma and transfuse it, or we could just give them we could thaw out some frozen plasma. Also, we've had puppies or animals that we know didn't get their colostrum. Maybe the mom rejected them, for example. We can take the mom's blood, centrifuge it, take the plasma and give it subcutaneously, or I think you can probably purchase plasma. So there's a lot of uses for plasma. The book talks about something called hyperimmune plasma, and I'll show you a video next week of that. This is plasma with higher than normal levels of antibodies, and so there's it's a horse ranch, I think, down near San Luis Obispo that I'll show you a video of next week. And then finally, cryoprecipitate. I don't know why they don't just call it von Willebrand factor, but I believe it's just plasma that has more von Willebrand factor than usual. And again, that's that little protein that helps platelets stick to each other. You did that buccal mucosal bleeding time test where Natasha took that little device that made that little incision. We're checking for von Willebrand disease with that. So you could, in theory, give a patient cryoprecipitate. You could give them von Willebrand factor. I don't know how long it lasts, probably not very long, but you could do that. Probably the least common type of transfusion is platelets. If a patient had a disease, it could be immune mediated, it could be certain infections will attack platelets. You could give platelets. The problem is platelets, they just don't last very long. You can give them, but then they'll get destroyed by the infection or by the body. So for some reason, when we have a hemolytic anemia, the body, I'm sure, will try to attack those red blood cells, but it seems to be more effective than giving platelets. Okay. If you need to take a break, of course, just pause this. Okay, so we're going to do a transfusion for Rocco. Again, I think we'll probably do whole blood or I'm sorry, we'll probably do packed red blood cells, but we need to know, we can't just give him any old blood, right? You've probably heard of things like transfusion reactions, incompatible blood types. You've probably heard terms like that. So we'll talk about that next. I'm not going to talk about selecting the perfect donor. The book does a pretty good job of describing if you have a donor, or some hospitals have like a population of owners who sign up to be donors. You obviously want them to be heartworm negative, etc. But you can read about that in the book. So we're concerned, right? We don't want a transfusion reaction between antibodies and antigens if Rocco receives an incompatible blood group. So let's review antibodies, antigens, and let's learn what blood groups are. And I'll use the word blood group or blood type. They mean the same thing. So antibodies, you may remember, right? These are these little Y-shaped proteins. There's different kinds: IgG, IgM, IgA. But these are produced by B lymphocytes. They're probably mostly IgG. Anyway, antibodies do some amazing things. In this case, well, you'll see. They coat foreign targets, and they allow other parts of the immune system to identify and neutralize them. They cause clumping or agglutination, and they're unique, right? The Staphylococcus antibody only targets, Staphylococcus. The Streptococcus antibody targets Streptococcus. The COVID antibody targets COVID. They're very specific for each target, and antibodies have to be able to. They're just proteins, but they we want them to attach to foreign invaders, not to our own blood cells or whatever cells. On your own cells, you have these little markers called self markers. Antibodies should not attach to those. There's a variety of other markers that we will call antigens that antibodies can attach to. And we call them antigen. Antigen means an antibody generator. Remember, antigen means antibody generator. And we learned last year, antigens could be part of that parasite, it could be part of a toxin, it could be a part of a cancer cell, but it can also be your own cells. If your body malfunctions and starts to and mistakes its own cells as foreign, then your own cells can be, we could consider that an antigen. But the bigger deal here, and that's what's happening with Rocco, but the bigger deal here is that a red blood cell from an incompatible donor could also act as an antigen. Part of the red blood cell could act as an antigen, right? We don't want it to, but it might. And right, that's what you're seeing here, right? This red blood cell has these little antigens, and there's these antibodies. You see how they're perfectly shaped to fit over that antigen. And this is where human blood types, this is where the terms like type A, type B, that's referring to antigens. And I want to go over this because it'll help you understand blood types in the animals, right? So and I'm leaving out the negative. If type O negative, type A negative, type O positive, that has to do with called the Rh factor, which I think is another kind of antigen. But I'm just going to leave that off because it's enough just to talk about these antigens. So if you're a type A, if that's your blood type, that means you have little antigens, little A antigens, right? If you're type B, you have little B antigens. If you're type AB, you've got both antigens. And if you're type O, you've got neither type. Now, in humans, there's a little extra thing that if you're type A, I don't know how, but somehow you're born making antibodies to type B, right? You see the little shape there? You see how it would fit right over those antigens? So if any of you are type A, you currently have antibodies to type B blood. And same with type B, right? Type B, you've got antigens to type A. If you're type AB, well, you don't have either type of antibody. Or if you're type O, you've got no antigens, but you have both types of antibodies, okay? So I had some questions here. I said, if your blood type is type A, which two blood types could you receive safely? Let's say you're type A and you need a blood transfusion. Which two blood types could you receive safely? And again, just ignore the, I'm sorry, gosh darn it. Where's my arrow? There it is, okay. Right? You're type A. Which type could you get? Well, obviously you could get type A. So that's one type you could get. And which of these others could you also get? Right? Remember, you have antibodies to type B. So obviously you can't get type B. You also can't get AB, right? Because your body would attack this part of the red blood cell. So you could get A or O. Type B, same thing. What two types could you get? Well, you could get type B or type O. Right? You can't get type A because you have antibodies to it. And you also can't get type AB because you make antibodies to that too. Right? So far, so good. If you're type AB blood, which three types could you receive safely? Actually, I didn't write that very well. I'm sorry. Yeah, I didn't write that very well. If you're type AB, I wrote which three blood types could you receive. You could actually receive any blood type. You could get all four, right? You could get, because you don't make any antibodies to anybody. So you could get type A or type B or type O, you'd be fine. And then finally, if you're type O blood though, you're born with anti-B and anti-A antibodies. Can you get this guy's blood? No, you'll attack that. This guy, nope. So if you're type O blood, you can only receive type O. Now I realize we just spent like 5 minutes on that, but I think it'll help you understand when we talk about other blood types. Because I think the book tries to explain, but it gets a little bit confusing. And so I've worked very hard to try to explain these other blood types, right? Because you and I, we have 4 blood groups or blood types. Dogs have more than 12, okay? Cats have 3, horses and cattle, they have just a vast number. All right. So here's our kind of our key messages here. So dogs have more than 12 blood groups, but what we do know is that some of those antigens are worse than others. What I mean is some of them are more immunogenic. And by immunogenic, I mean it means they will stimulate the immune system. If some antigens are more immunogenic, that means they're going to they're going to activate the immune system more than other antigens. So in other words, yes, some of these canine blood groups are worse than others. Cats have 3 blood types, but they also have some additional frustrating qualities. And then, like I said, horses and cattle, there's no true blood type known because there's so many different systems and factors, but there's still a few factors that we screen for in donors. In other words, the donors, we don't want them to have these immunogenic antigens. There's certain antigens that we really want to avoid, or at least we need to make sure that both the donor and the recipient have the same immunogenic antigens. But to explain with dogs, since that's probably most blood transfusions are going to involve dogs, and if you can understand this, it'll help you understand everything. So I just want you to imagine a dog, and I actually gave you some little antigens that I want you to draw on. So I gave you some not antigens. I gave you some blank red blood cells for you to draw on. So let's imagine a dog whose red blood cells had no antigens on it, right? There it is. There's probably no such dog, but let's just pretend, right? So this dog has red blood cells with no antigens, and let's say he needs a transfusion. Okay, now this is the second dog. This is going to be your potential blood donor, but I'm just telling you this would be the worst blood donor in the world, and I'll explain why. There's 3 particular antigens. I don't know why they named them this, but there's 3 dog antigens. They call them dog erythrocyte antigens, and they are called 1.1, 1.2, and 7. Right? Just like you have A or B, dogs have 1.1, 1.2, and 7. I don't know why they didn't just call them A, B, C, D, E, F. I don't know why. These are the most immunogenic antigens, right? They're the most likely to stimulate production of antibodies. That's bad. And of those 3, 1.1 is the worst. And in fact, those of you who bring in some dogs next Wednesday, that's what we're going to test for. We're going to test to see if they are 1.1 positive or 1.1 negative. It doesn't mean there's anything wrong with your dog. You'll see what it means. So let's imagine if we transfuse the blood of the second dog, that's this red blood cell here, into the first dog. These are his red blood cells, right? So this is the recipient, and this is the donor. There's the donor. There's the donor. There's the donor. Okay. What's going to happen, right? The recipient, what's the recipient's, B lymphocytes going to do? Well, they're going to see these as foreign, right? These are highly immunogenic antigens. So the recipient is going to start to make antibodies. That's not good. He's going to start making antibodies to attack 1.1, 1.2, and 7. Is that a problem? Yeah, but it takes a long time. It's just like when you give that first parvo vaccine or that first West Nile virus vaccine or whatever. It takes weeks before the patient makes antibodies. It's when we give that second vaccine that we kind of boosts the production. So it takes a while. It takes a few weeks. And so this is why the book will tell you, and some people will tell you, for first transfusion, the dog will probably be okay. We can give this wrong blood type, you know, yeah, he's going to make antibodies, but it'll take, you know, 10 days or so, and by then he'll probably be okay. Now, I said probably. In general, we don't want to do this. We'll see more this week, and there's a video I'll show you next week. Now remember, in humans are born. You are born with these antibodies that will attack the wrong blood cell, right? Dogs are not. Those are called alloantibodies, and dogs are not born with them. So those antibodies, like I said, it'll take some time for them to develop. But now what happens if the same dog receives another incompatible transfusion? Let's say it's, whatever, 2 weeks later or 2 years later. Well, now he's going to make antibodies within hours. Within hours, he'll make antibodies, and he'll destroy the donor's red blood cells, and he'll set off a potentially deadly transfusion reaction. I mean, it'll be a very violent reaction. So what do we do? And we'll learn more about, like, how do you make sure the donor and the recipient are compatible? We'll talk more about that in a little bit, and we'll certainly be doing that in lab next week. But it would be nice if we had a universal donor, just like in humans. Whoever is type O blood, they are a universal donor. Anybody can take type O blood because there's no antigens. There's nothing, if you have, there's no antigens to stimulate antibody production, right? So that's why type O is considered the universal donor, and type AB is called the universal recipient, because this person can take any blood type, and this person can donate to anybody. Okay. So it'd be nice if we had a universal donor in the dog world. So what would make a universal canine donor, right? In other words, right, he'd be the type O blood donor of the dog world, he or she. Well, for starters, right, we don't want them to have 1.1, 1.2, or 7. Again, we just have to, it's a little hard to wrap your mind around, but, like, remember, dogs could have any combination. And there's at least, what did we say, how many blood types? Depending on who you ask, there's like 12 different antigens, right? So there's just hundreds of possibilities of different combinations. A dog could have 1.1, and I don't even know what the others are called. If they're called 1.12, I don't know. The point is, there's a lot of combinations. Okay, so to have a donor, ideally they'd have no antigens, but that's impossible. Okay, so we would also we don't want them to have these really immunogenic antigens. 1.1, 1.2, 7, no. We don't want them to have that. We will allow them to have an antigen called DEA number 4. So the ideal dog donor would have only DEA4. Why? Because most dogs on this planet have DEA4, right? 98% of dogs have that. In other words, they're not ever going to make, they won't make antibodies to DEA4 because they already have DEA4. So DEA4 would be okay. All right. Now there's a little problem with that because only 15% of dogs are like that, right? Only 15% of dogs have DEA4 and nothing else, or very few things. In other words, only 15% of dogs would be able to be a universal donor. Now these dogs do exist, oh, that's weird. Sorry. I meant to put that here. the breed of dog most likely to fit this description are greyhounds. Greyhounds are most likely to have only DEA4. And so if you ever go to work for a blood bank or ever work with a blood bank, they have like a population usually of greyhounds. So anyway, and we'll talk more about that. Okay, but again, that's kind of a small pool. And so if you work with blood banks or if you order blood products for your hospital, we will allow DEA 1.1 positive dogs to be a donor. That's a pretty common blood type, antigen. But they can only donate if the recipient is also 1.1 positive. So, so that would be okay, but ideally the donor would be, negative for 1.1 and 1.2. But this is just showing you. And if you're getting a little bit, if your head is starting to spin, believe me, I'm with you. But don't overthink this. So for example, if the donor was DEA 1.1 positive, the recipient, they could take blood from this dog right here, right? And they could take blood from this dog, right? Either one would be fine. But if the dog is DEA 1.1 negative, can we give him blood from this dog? No, we cannot. We really don't want to, because he will start to make antibodies against 1.1. And again, if we go, there's a few different blood banks. There's Hemopets, there's Animal Blood Resources. They used to be in Dixon, and I think now they're in Orland. And you can here's here's a file of dogs that are 1.1 negative. There are some, and I probably should learn more about that. There are some groups that think that we should end animal blood banks, because these dogs are, these dogs live there just to act as blood donors. And I don't know a lot about them. My experience with them is these dogs have a pretty good life. They're out in kennels and running and playing, and just periodically they get their blood drawn, and then it gets banked. So, but again, I don't, I probably should learn a little more about it. But I've seen these blood banks, and I think these guys and gals have a pretty good life. But yes, they do get their blood drawn. It's their blood is drawn by there's veterinary technicians run these places and work there, and I think they all do an awesome job, and they save lives, because when you need blood, you need blood. Okay, I'm probably running way over time, but okay, that's okay. I mean, I think it'll help you understand the reading if I keep talking. So cats are a little different. Now, they're a little easier to understand in one way. They only have 3 blood groups. Yay! They do have alloantibodies, and that means that even a first transfusion could be fatal if it's incompatible. So a first incompatible blood transfusion could be fatal in a cat. And I'll explain that. The 3 blood groups are A, B, and AB, and in reality, you're going to go your whole career and you're only going to see group A, right? You'll probably never see group B, and you'll really probably never see group AB. So group A would be, domestic short hairs, kind of your basic cat, right? 90 to 99% of cats, 95 to 99% of cats are group A. And they have high levels. They're born with high levels of anti-B. And the flip side is group B cats are going to have high levels of anti-A. And you're not going to see very much group B. It is seen in breeds like the Devon Rex. You see him here, and the British Shorthair. But even the Devon Rex, the British Shorthair, it's only like 40% of them. Even most of them, or a lot of them, are going to be group A. And then finally, group AB cats. These would be the universal recipient. They don't have, because they have the A and the B on their red blood cells. Well, they don't have any allo antibodies, so they could take anybody's blood, but they're very rare, right? So, like we said, now there's a bit of a difference in who would have the worst reaction. So, oh, this is from last year. I'm sorry. Let me just change this real quick here. I was using, well, you know, Prince. There was a cat named Taz that okay. I'm going to try something. I'm actually going to stop this recording, and then we'll continue this in like part 3.